For those of you that don't know me, my name is Lauren Pretorius. I come from a patient advocacy organization in South Africa. I'm the CEO there for my sins. And today we've been asked to talk about making sense of medicine access. We've got two amazing speakers today and a panel, and I'm sure that after we've done this, we'll have solved all the questions you have to answer. We'd also made sure that there are a long-standing world peace and that unicorns are real. So what I want to do, something someone asks me, or I am often asked as a patient advocate, is what does innovation mean to patients? To hear this word innovation, and it's an exciting word and people get excited about it, but unfortunately, sometimes we have to throw a little bit of a damper and some cold water on it, because the idea of innovation means nothing if it doesn't get to the patient. If it doesn't reach the patient, all that money we spent on that innovation is a waste of money. If it's sitting on the shelf somewhere and those patients can't access it, we wasted all those billions of dollars in the work and the hard work and the brain capacity and the talents that were put into that innovation. It's all wasted if it doesn't land up in the patient, at the patient. I think at this time, you know, we're looking at times where things are shifting and in a time of disruption. And I don't know about you, but at night when I close my eyes, there are a few questions that run through my mind. And those questions are, you know, how do we get to the point where a medicine starts as an idea in a scientist's mind to getting it to regulatory and getting it to the patient? Or what, you know, why are people making the decisions they do to approve a medicine and make the price of that medicine and then decide to reimburse it? What are the things that do that? And, you know, why is it different for every country? You know, are their health systems different? Are our health systems so different? I have an 8-year-old, oh God, he's 10. Don't let him hear me that I said he was 8. I have a 10-year-old nephew, and if you had to ask him what he wanted to be, he'd say a soldier. But if you really had to ask him, he's a lawyer, right? The guy sees black and white, although there's lots of gray when he wants to, especially if you're playing Monopoly, and he makes the rules up on his own. But he's a little boy that puts things quite plainly, and I love that about him. And the other day he heard about human rights, and he said to me, you know, Tanya Lauren, what are human rights? And I mean, I should know that, right? I should have well, human rights are. And I started with my bumbling and that, and I said to him, well, boy, it's because a human right is like your health. You have to have health. And I said, because you were born and you're human, and that's why you should have health care. And that health care is a human right. And he looked at me, and I could see it hadn't hit, and he wasn't impressed with my thing. And he looked at me, and he said, so you mean because I didn't ask to be born, I have to have it? And I said, yes, that's exactly it. You didn't ask to be born. You didn't ask to be born, and for that reason, we give it to you automatically. And I thought it was such a simple way of thinking about a human right, an integral human right on someone, is that none of us asked to be born. None of us asked to be born where we were born. None of us asked to have a disease that we have. But because we are human, we instill that right that you should be able to be healthy. So what we thought we would do is we would get two very clever and well-versed people to come and chat to us about this. And I'm going to ask from a presentation. Our first presenter is Mihai Rotaru, and we had a lovely discussion yesterday. Mihai is the Associate Director of Market Access in the Economic and Social Affairs at the EFPIA. And he is going to help us understand a little bit about the data on access gaps, particularly on the recent EFPIA's publication on weight, and what we can look at, what are the root causes when it comes to clarifying why there are delays in patients receiving treatment, or the regulatory delays, and how long those are. So I think after that we'll have another presenter, but it'll be online, Robert Sauermann, who is the head of the pharmaceutical department at the Austrian Federation of Social Insurance. And what we wanted to do here in this session was make sure that we had focus from patients, from payers, and from regulatory. So I'd thank you, and I'm going to give you the clicker, and you can, I don't know if you want to present from here, or...
Yeah, sure.
Okay, fantastic. It's a sit-down kind of topic.
I think it's more of a conversation rather than a presentation, honestly.
Okay.
So, good afternoon, everybody. Thank you very much, Lauren, for the introduction. Thank you very much for all of you for the invitation, for having me here today. I'm going to try to stick to 8 to 10 minutes. I'm going to throw some graph charts at you. Please don't take it, don't hold it against me. I'm going to try to go as quickly as I can, and in any case, the slides will be shared with all of you afterwards. So as Lauren has mentioned, what I'll try to do is, obviously at EFPIA, so we operate in the European context, in the European environment, and you know very well there's a single regulatory authorization, a single EMA marketing authorization, but then there's 27 different national decisions on access and reimbursement. So obviously we are very interested and very keen in ensuring, first and foremost, that medicines reach all 27 member states, and if they don't, to really understand what are the reasons and the factors driving this unavailability. So I'm going to walk you through some slides on this so-called patient weight indicator. So it's cleverly named as patients waiting for access to innovative therapies, and then the access hurdles report. Just in a snapshot, we capture availability, time to availability, and availability of new innovative medicines. Just a quick summary in terms of what we see as observations across time. So we see an increase in medicines not available at all, and we also see an increase in the limited availability of medicines overall, and I'll explain this as we go along. So this is probably not going to surprise anybody. We know all of this, and this is a data cut for oncology, that the availability varies significantly across member states. So we have here a data cohort of 56 oncology medicines approved over a 4-year period, 2020 to 2023. And you can see here the gradient as it goes further to your right in terms of as you move across member states. When we take a more detailed breakdown of total availability, this is an interesting chart that we like to use, because availability turns out, or it is recently more of a gray area, as Lauren has mentioned. There are circumstances where it's either black and white, but we also see that there are certain circumstances where there's limited availability of medicine. So, for example, there could be restrictions to subpopulations, for example. There's also individual patient basis availability, and we also capture instances where the medicine is privately available, meaning it is available on the private market. I should mention that obviously for EFPIA and for industry, we consider that when we talk about availability, we mean full availability, and we understand it as positive listing on a positive reimbursement list by a member states. But that's only the first step. We're not yet talking about uptake. I'm sure we're going to come to uptake in a couple of minutes. When we look at time to availability, again, this is not going to surprise anybody. We see that the variation is quite significant. I like to use the box and whiskers chart, because it does show that there are plenty of instances where medicines are available quite fast, but there are also plenty of instances where medicines are delayed and delayed and delayed, and this is across the board. And then, as you see, the median time tends to increase as you go from Western Europe to Southern Europe to Central Eastern Europe. And I'll stop. So this is on terms of availability. What we did at EFPIA and what we're doing at EFPIA is we're trying to delve further into detail into the reasons why there are these gaps, into the reasons or what are some of the root causes of unavailability. So the information that I showed so far is based on publicly available information. What I'm going to do in the next 3 slides is to cover information reported by companies. So self-reporting by companies in terms of what are exactly the reasons why there might be delays in the launch of medicine. The cohort of product is not 100% overlapping, but I think you can trust that the trends are more or less consistent. Like previously I was talking about oncology medicine. Here we're going to talk about all innovative medicines, all newly approved EMA medicine. So what we can observe, but this is also an impact of simply of measurement. So if a medicine was not available at a certain point in time, that doesn't mean that it will never be available. So here we see in many instances, if the medicine is unavailable today, it probably means that it has been filed for pricing and reimbursement, but a decision has not yet been reached. So you can see here that there are the gradient is slightly better, if you will, in terms of medicines being in the process of being approved. And even if they have not yet been filed, there are instances where the medicine is available through alternative access schemes. And I'm sure we're gonna cover this discussion in a minute, but we know very well that it is the company's responsibility to first file for pricing and reimbursement. That is indeed a first step at national level. And we have heard numerous times in the past that if there is a delay in unavailability is simply because companies don't launch the product. And what we can see from our internal data is that if you take the full time of the delay, there's only 31% of the delay can be attributed to the fact that the medicine was launched a little bit later, and 69% of the time is simply by virtue of the length of the pricing and reimbursement process and decision at national level. And here we're going to go into some of the more detailed reasons why companies may not be launching yet medicines on certain markets. So what are some reasons for non-filing across regions? And you can see, and probably this is again not going to surprise anybody, we see a difference in the reasons between Western European countries, Nordics, Southerns, and CE. And here, in terms of the reason, you can see probably what you might expect in terms of healthcare infrastructure, size of the treatable population, lack of company presence, country filing requirements, low value attributed to competitors, and so on and so forth. So obviously the picture is very diverse across member states, and it does go to a certain extent towards explaining why we see the difference in availability and the time to availability. And I'm just going to finish here with some of the key observations, just to summarize, to say historically full availability was the main access route. Now restrictions are more common. Limited availability is potentially a good thing for the patients that do get access to that, but it's a suboptimal outcome. I think we all have an interest in availability being across the board. Early access programs, they are a good idea in some instances, but they shouldn't come at the expense of achieving full availability. I talked about availability doesn't mean the same as uptake. So uptake is a separate measurement in terms of how many patients actually get access to medicine once the medicine is reimbursed. Multiple interconnecting factors driving this divergence. Part of the total time between EMA approval and availability can be attributed to companies. And then last and not least, obviously, access to innovative therapies is a shared responsibility, and obviously we all need to do better. So Lauren, I'm going to stop here, and we're going to continue in the conversation.
Thank you very much. Thank you. We're now going to go over to Robert. Robert, good day. Can you hear us?
Hello. Yes, I can very well.
Fantastic. Robert, thank you for joining us. I'm happy if you want to put forward your remarks. I don't know if you have slides, but we can, I'm sure that...
Well, actually, I do not have specific slides. Thank you for inviting me. I'm unfortunately was not able to come to make it to Brussels today, but I'm happy to share some thoughts with you. Just who am I? Who are we? I represent the Austrian health insurance. We are a country of around 9 million inhabitants, and we have a system with health insurances, and these health insurances are self-governed, and they are responsible essentially for the outpatient sector. So we have a country which is has a hospital sector, which is a responsibility of the regions, and the outpatient sector, which is more of a responsibility of the health insurances. And taking us as an example, this may be also one explanation, the specific structures of every country. So in Austria, it's like that. In other countries, it's different. And this also has an effect, positive or negative, on access. What we do is we have a positive list of drugs. It's called the ECO, the Code of Reimbursement, and this positive ECO list includes thousands of different drugs, from hypertension to modern oncology therapies for the outpatient sector. And we have an application system, so companies can apply at our institution to get on this positive list, and we do the HTA assessment and are responsible for the next step of negotiations and for coming to a decision. And the challenges are pretty the same in several countries. But what do health insurances or health systems in general want to? So what we want to achieve is that all patients and all insured people get the therapy that they need. And so this is our motivation to do everything. And in Austria, we saw it on the slides that Mihai showed, is one of the earlier countries where drugs get launched, and a lot of drugs get launched. So what we try is that we critically reflect the term of the innovation that Lauren mentioned, because we think an innovation is an innovation if it really brings a step forward for the patient and not in the lab or not in a surrogate marker or something. It's nice if a laboratory parameter gets better or worse, but in the end, it's can we achieve an improvement in life, in quality of life, or something comparable for the patient. And what we try is to evaluate this innovation and to evaluate the benefit for the patient. And for those drugs that give a benefit, we try to have them early, but target orientated. So if a drug is new, and that's a fact, there are many uncertainties. So we do not know a lot of this drug, and sometimes we know pretty little. So it's a promise that there might be an improvement, a hope that there might be improvement, but we do not know everything about this drug. So we try to get it to Austria, but to give the access very target oriented to maybe to a small population where we hope that they will benefit. And then when we get more experience and when we get more data, we try to reevaluate, maybe to renegotiate, because after 2 years or 3, we can also make a better statement on the price relationship to the effect. Effect-price relationship is an important thing. And then position the drug in a different way. broaden it or restrict it. And that's of course a challenge, and a challenge that all health systems face. So what do we have in common with other health systems? I think one big thing is that the drugs are affordable. Because if we spend lots of money on one topic, then we have not enough for a lot of other diseases, and this would not be sustainable. So the affordability and the pricing are essential issues for us, and we try in the dialogue with the companies to address these issues and to come to solutions. Sometimes it's easy solutions, sometimes we need managed entry agreements with some special aspects, with the data collection or with a more complicated price scheme. And then we have some other pricing requirements, but the overall goal is to combine a good access with some sustainable budgets to be the benefit of everybody. And maybe I stop here with my initial statement.
Thank you, Robert. If we can just leave the Robert up, because I'm going to ask some questions now. On the prompt that I was given, it was for me to answer that, but I think that you've heard enough of what I have to say for the week. So I'm going to push it back to the audience. But I'm first going to ask our presenter, Mihai, if the question, but then I'm going to put it out to the audience as well. So we're not going to hear from Lauren, we're going to hear from the audience on the answer. So we'll see how those answers differ. So the EFPIA PIA's report points to multiple routes and causes for the delays. You mentioned some of them for delays and unavailability. Which of these do you feel are the most important to tackle? And what are the practical solutions currently on the table? So that's for the entire room. We'll let the speakers answer first, but I want to hear from you in the room on which of the reasons for the delays are the most important, do you feel, to tackle, and do you as organizations have any practical solutions on the table for that? Thank you.
Yep, thank you, Lauren. And I think some of the solutions were discussed earlier this morning. I think Robert also pointed in his introduction to some of them. I would say that from an industry point of view, we agree as well that the evidence package is an important, let's say, deliverable. It is an important piece that companies need to bring forward when they launch their new medicine. So it's all the elements around HTA and pricing and reimbursement. We heard earlier today a very good introduction on what HTA and what the European HTA regulation is supposed to do from ANCA. And I think working together with stakeholders and with payers as well on novel pricing and reimbursement models is a good solution. So Robert mentioned managed entry agreements. We know of examples of pay for performance or coverage with evidence development. That's more on the regulatory side, but it can apply also on the access side. I would say for me, so Lauren, to answer the question, that's probably one of the major areas where we can work together. I think Robert mentioned it very, very clearly. New medicines are developed. They are new by the virtue of them being called new. So it is indeed, there is sometimes no experience with using the medicine in a clinical practice. It's only in a clinical trial in a much more controlled environment. So how do you extrapolate from that controlled environment into clinical practice? That is the key question. And then obviously for us and for patients and also for payers, there's an interesting debate to be had in terms of is it better to make a type 2 error or a type 1 error? That's to be discussed. But I think novel payment models are a good way to explore possible solutions. Also, on behalf of industry, we stand by our products, and we are happy also to develop the co-solution with the payers to make sure that our medicine work as written on the box.
Okay. Any comments from the audience on that? Yes. Carl Henrik, can we have a microphone, please? Just for, thank you. Thanks.
Hello, I'm Carl Henrik Sundin from Sweden. We have HTA or so on, but this regulation has nothing to do who will pay, and that takes. So I think it's, and those who the discussion about how much it will cost is behind closed doors, so you don't know the price. And it's the same in Austria too, and the same in France and so on. So the industry wants to keep its. So I just can't understand why all countries can go together and negotiate and have the price, and so it's clear. That's what it costs. Then you can also include it in the HTA before. It's worthless HTA without having solved the costs.
Yeah, I think it comes to, thank you for that. I think it comes to, and we see it in South Africa a lot, I think it comes to the point of what different countries can afford, and the way that pricing, and you can comment on this, but the way that pricing is to look at what the different countries can afford, and then put HTA on top of that to look if it's of value, and then does the country have the budget to pay for it? For me, it's understanding that what it shows is how complicated this is. And I think that if we understood how the decisions were made in transparency on that, that might be something that we could take forward. I know that that's one of the things that HTA is trying to do. Well, is good, and as Anka said, is it creates that transparency for everyone. Mihai, do you want to?
Yeah, just to add a couple of notes, and then I'll hand over to Robert, because I don't want to speak on his behalf. I think I would say that indeed some of these decisions, or a part of these decisions, are made, as you've said, behind closed doors, but they're not made by strangers. I would say, and again, I'm going to put words into Robert's mouth, and he can correct me. I would say his interest, he works, or payers in general, work and operate on behalf of patients, on behalf of the society in which they operate. They're not strangers. It's not the people that make these decisions make the decisions in the interest of their co-citizens, if you will. It's not a foreign body. It's not, I know it's very easy to say, well, if it's behind closed doors, then it's obviously something very fishy and very, very suspicious. But right now, and we believe, and we continue to believe, that doing it so enables the countries to make the best decisions for their specific circumstances, and in a lot of the situations, doing it like this also enables them to make faster decisions compared to what otherwise might have been the case if everything were to be done completely in a transparent environment.
Robert.
Okay, so if we start from the question, why is there a timely delay between the approval and access in different countries? I mean, I think one thing is it's for commercial reasons. I don't want to criticize that, but if you have a look at the map where it comes early and late and not at all, so and it has to do with economic strength somehow. So it's for commercial reasons. And we much depend on the willingness and initiative of companies to come. So it's also in Austria the same, because it's an application system. So if companies come, we can talk about, we can negotiate and try to find a solution. If they do not come, so we are waiting, and so that's and that has a commercial background. Then the other question was from the audience, why? So we have a joint clinical HTA, but different negotiations elsewhere. I think, and it was answered already, we have different economic possibilities in countries and different national willingness to pay, or systems, or we have systems where you have a cost effectiveness threshold, and you say, okay, if we're willing to pay so many euros for one life year gained, and then there are other countries like Austria, or I suppose Germany, where such thresholds would not be accepted by the society, and this makes it difficult to negotiate together. But what we see also from our collaboration, which we have with other countries, for instance, in the Benelux initiative, where Netherlands, Belgium, Ireland, Luxembourg, and Austria are included, and we have the opportunity to do a HTA together and to do a joint pricing negotiation with the 5 countries. That companies are not rushing to use this possibility. It's voluntary. So in contrast, they are a bit maybe suspicious or reluctant to negotiate with 5 countries together, because we don't know what would come out, and would I have then to lower the price, or is the pressure on the company bigger than? So I think it's a mixture of countries that want to maintain their autonomy in the decisions where they invest or where they do not invest, and how much they invest. But also the companies that are not asking for more joint negotiations. And so the solution, so one thing is we need the company to engage. And if they engage, okay, then we have other hurdles, so other challenges. So do we agree on the benefit of a drug, and do we agree on the price, and what is an acceptable or adequate price? But it's good even to get there, to get to this level. And one of the challenges is the uncertainty. That's unfortunately I didn't hear the sessions in the morning, but the uncertainty, because we do not know for us how much will a drug be used, how many patients will there be, will the treatment be as long as in the trial, or will it last longer, will the effect be the same? Yeah. And many drugs with open trials, no uncontrolled trials or evidence, this makes it different, because we are responsible as a payer for the money of the insured, of the tax money. And if we give a lot of money to a possible innovation, but it's possible, so it might help, but there's no evidence. And on the other hand, this was a research drug. It took a lot of cost to develop the drug, but then there's still this uncertainty, and this uncertainty to put a lot of money in something that might work is one of our challenges as payers as well.
So, Robert, I think one of the things that, I'm picking up from Carl Hendrik's thing is, and what both of you have described, is there is a industry coming to the payer, and industry being willing to bring that medicine to the payer at a certain price, and then the payer's willingness to pay. And there's that negotiation that happens. In between all that, there's a patient or a citizen that needs that. And I think that up until now we've spoken about HTA and the inclusion. I think that's why it's so important to have the inclusion of patients' perspectives in these processes. How, from your perspective, Robert, you've mentioned some of the challenges that you're facing on deciding with medicines. How could patient advocates support your decisions? How could they add to the real-world evidence or to the social and ethical evidence that's required for your willingness to pay?
Well, for the drug evaluation committee that we have in the outpatient sector, so we do not have a real patient representative in the committee. So we have of the physician's chamber and of the economic chamber, and then we have of the working chamber somebody who is supposed to represent the people, and so different voices in this commission. And then we have newer commissions, for instance, for the hospital sector or for those drugs at the interface, where it is, which was established last year in Austria, which was new, and where the patient societies are routinely involved. And I can only speak of my personal experience where it's not institutionalized. I see sometimes it's very useful to have these talks not only with physicians who work in the field, so not only with HDA, not only with EMA, but also to talk to patients' representatives who know the community who suffers from a certain disease, and to learn from their needs and from their and practical aspects or regarding aspects in use. So I think this communication is very valuable and enlightening. I think what I maybe, or what would I not want, or what do I say, that is if patients cannot act independent. So it's okay, it's financed. We have social insurance, we finance patient organizations because we want them to be independent, and they receive some public money in such a sense. But there are many organizations also receive money from companies. And I think here my expectation would be that this is handled in a transparent way. So, and that the patient representatives do not get under suspicion of becoming a voice of industry, or just to be pushy in the sense of we want. So, but I think this is an impression that's not good to the sake. So it's good if they have want to communicate their needs to the institution, to the health system, that this can happen in a independent way, in a transparent way, in a trustful way.
Yeah. It always makes me chuckle, and with my dry sense of humor on this discussion when it comes to transparency and how those are monitored, to think that as a patient I got into this from a passionate point of view, and that my integrity is for sale seems a little bit out there if you think about it. One of the things that I want to put it out for a last question, one more question to the audience. You got Alex?
I just have a quick question, and I'm sorry, I was out in the room for a little bit, so if I've missed this, I apologize. But could we touch on reference pricing? Because I know in South Africa, it's also an element that leads to access issues, and I think for some majority of our community, it would be helpful to know about the challenges related to that. So if you could touch on this.
Okay, I'm going to let you take that one, and I'll...
Yeah, thank you, Alex. So I think we see reference pricing as an issue in Europe as well. I think just to make it, to put it very, very, very bluntly, if a country has to reference 10 other countries beforehand, or 14, or however many, by very definition, you can only be country number 11. If you have to wait for 10 other countries to make their decision first, then by very definition, you can only be number 11. Now, I understand that this might be done for budgetary reason. I understand that, of course, people have a certain human desire to know what the neighbors are paying, if you will, but that's a little bit the trade-off, especially with external reference pricing. For me, the trade-off is that the country that makes use of such a tool simply has to wait longer than otherwise.
Yeah, I think coming from a country that, or a region where a lot of the time there has been, well, there are short, resources are scarce. We live in a world where the haves pay for the have-nots in different ways. It's not only at a country level, it's at a societal level, it's at a family level, it's at a community level. That's the nature of humanity. And you know, that system is in place. At the moment now, we sit in a situation that South Africa has been open about what they're paying in a transparent way, and they publish that so that the world can see what they're paying. But that impact is that we're not getting prices that are relevant to our communities and to our economic, because we're referenced as a price. So the rest of the world goes and looks at it and says, okay, well, South Africa's paying this, we should be, in our mind, paying X amount more, X amount less than South Africa. And for that reason, now we're sitting in a situation where our prices are sometimes higher than the actual prices that they're paying for medications in the UK because of that. So it's interesting to see how some of the ways that pricing and the negotiations around this happens, that we're understanding that we're all different, our capabilities are different, and I think for me that's one of the places that it doesn't go to the final reimbursement decision, because there are a lot of things that go into that, but that's for me where value-based care and HCAs and things like that come in. Because if you truly have innovation, and not incremental innovation, like innovation, let's not say that innovation means new. Innovation means this is something special, and it's someone thought about this and it doesn't exist. If you truly have innovation, then it has value on that, and the value is higher than what if you didn't have innovation. And I think that's where we're losing it, is what we define as innovation today. Because if everything is innovation, then the water just gets muddy on what we think is special and what is not special. I'm going to ask a last question to both our panelists as closing. So, you know, there's always going to be this push and pull and potentially this misunderstanding, or we're going to agree to disagree when it comes to patients, payers, and manufacturers or developers and innovative things. We're going to agree, we're not going to agree, we sometimes are going to argue with each other, we're going to work together, but at the end of the day, we all need each other. Not one of us would exist without the other. It's unfortunately, it's like the family you didn't want, all right? You're in it, and you've got to find out a solution. And my question to you is, for both panelists, if Robert and Mihai, if you could look at, what is the most promising opportunities for collaboration between patients, policymakers, industry, payers, to make access fairer and faster? What are those? Where do we see the collaboration with patients happening?
Do you want me to go first?
Robert, you can go first. You spoke first, and then we'll let. Sorry, you spoke second. Then we'll let Mihai finish.
Okay. What can we do to make it better? I think we can. What we try is to make good managed entry agreements. So that's in some cases where there is no other solutions, we find some pricing model or steps in pricing or some cap or some with or without data collection to find a solution to make access possible to some innovation and to give the security to the pharmacy to the company that they can earn good money for their development, and for us the security that the budget impact will not go out of a reasonable magnitude. So this is a thing, and I think that when choosing such drugs and when we negotiate, it's good to know the need of the patient and to differentiate what's what you mentioned, Lauren, what is the real innovation, and what are the products that are more needed or less needed, and how they are needed. So also when we define the criteria for use, for instance, where should a drug be used, and all these questions, the input of the patients is valuable, and or in the region. So also this question between specialization, that you get high numbers at the center, so that there's enough experience which benefits the patient, and enough numbers. And on the other hand, and I think that in South Africa and elsewhere, it's also a topic that the country is spread and you have different regions, and to find the balance for an optimal treatment and a good quality treatment.
Hi.
So I agree. I very much agree with what Robert says. I think what I could add is that it's great to be able to have these conversations. I think what I would say personally is that we need a little bit more honesty with ourselves and with each other. I think we need a bit more honesty with each other and with ourselves when it comes to our interest. Of course, obviously, pharmaceutical companies, they are commercial entities. They have a profit motive as well. They have other motives as well. I think social insurances also have a budgetary motive as well, and so on and so forth. But there is a middle ground somewhere, and I think we need to agree about what we agree to talk about. I think even now in the last 45 minutes, we talked briefly about value-based healthcare. We talked about value-based pricing, but somehow with one eye looking at the neighbors. Well, I want to do value-based pricing, but I don't want to do it more. I'm not holier than the Pope. I don't want to do it at a price that is a lot bigger than my neighbor, if you will. So that's normal. That's perfectly fine. I'm just saying that I think having more transparency of where we're coming from and what are we trying to achieve and of our own interests is a good step forward. And eventually, we're going to find a middle ground. And I think what I would say, Lauren, to finish is the reason why I want to and I like to keep doing it, and I have no problem arguing with you here or with others and so on and so forth, is because I know the innovation of today is the generics of tomorrow. I know that I'll do this day after day after day, and in 10 years' time, I'll look at the past arguments and I'll say, well, that was interesting, but at the end of the day, now it's a generic medicine. Everybody has access to it. It was a fight worth having 10 years ago. So what I'm doing today is so that 10 years from now, I'm going to say, well, it was a good, okay, not a fight. It was a good argument to have.
Thank you. I think in closing, I want to put a call out to my fellow advocates. This is an area that can be very complicated, very emotional. But I'll never forget 16 years ago, there was a discussion in South Africa. We were brand new advocates. We'd sort of fallen into it. We decided that we would sue a payer to make sure that they would pay for something in breast cancer. And we would then realize that we were locked out of the conversation. And we had to almost go to court to get into the conversation. And we fought so hard to get into the conversation that when we got actually into the room and realized what we got ourselves into, we turned around and we were like, well, now what do we do? We've like literally got ourselves into this room, and now I don't understand half of what they're saying. And it can be overwhelming, but it changes, because you do know more than, and you have something to offer. You have real experience, you have real world data, you have real lived experience, and that is what creates the perspective of humanity on these conversations. So my plea to all of you is to get involved in this, understand the processes in your country, and be involved and add that lens of humanity onto these conversations. Thank you very much.
Thank you.
Thank you.